Hi, this is Ginger Keene, and we will be reviewing pacemakers in this lecture. Uh, our objectives is basically state the indications for pacing, and first we'll talk about the different types of pacemakers. Then we will learn to interpret the pace rhythms. So there's different types such as transcutaneous, transvenous, epicardial. Those are considered temporary, and the permanents are single chamber, dual chamber, and biventricular. And when we define the pacemaker terms, we're looking at pace beats, capture, demand, and asynchronous. We also will need to identify what's normal and abnormal pacing rhythms. So why do we pace? It is usually due to a bradycardia, a symptomatic bradycardia. So if your heart rate is too slow, again, heart rate times stroke volume will decrease, it causes a cardiac output. So if your heart rate is too slow, you will have a decreased cardiac output. We also need to maintain synchronous function of the cardiac contraction, usually used for different types of permanent pacers. We also will use pacers as a temporary measure to use to maintain the patient's heart rate in an emergency situation. So not everyone who gets a temporary pacer will have a permanent pacer. In the setting of an acute MI, patients may have transient bradycardias due to the inflammation or injury to the conduction system from the ischemia that may improve in a few days, and they don't end up needing a permanent pacer. And not everyone who gets a permanent pacer will have needed a temporary. So what do we usually pace? So we can pace the atrium in a temporary or permanent pacer, ventricles, temporary or permanent, and we can also do both atria and ventricles, temporary and permanent pacers. If you can also pace the atria and both ventricles, but this is actually a permanent pacer only. So how do we pace patients? All pacers have two components. A generator, which for permanent pacers, they will be internally surgically placed within the myocardium, or there's external devices for temporary. The leads, these leads again surgically would be inserted into the myocardium, or if there's external or temporary measures of pacing, they can be placed with pads on the skin, a catheter inserted through the IJ, subclavian, or epicardial wires that sit on the outside of the heart for temporary use. We're going to talk about each of these. First, temporary pacemakers, the different types. You have transcutaneous, which we will also refer to as external, transvenous, and epicardial. First, let's talk about transcutaneous pacemakers or external pacers. Usually, these transcutaneous pacers are used as a bridge or other therapy. So we usually will have a patient that maybe has a medication that is maybe causing them a bradycardia, but once the medication has gotten out of their system, they will no longer need a pacemaker. Or there was a patient who came to the ED very bradycardic, who was a hemodialysis patient with her K at 8.8. A transcutaneous pacer was being used in the emergency until emergency hemodialysis got the K down, and she was intubated and sedated. She hadn't missed dialysis, but what she did do was she tried a new recipe with a lot of tomato sauce, according to her husband, that shot her K up. So in this terms of a transcutaneous pacemaker, they only are pacing the ventricle, and it's used in an emergency situation in a very short-term use because it is very painful, and the patient usually feels it, so we may want to consider pain medication and sedation. And as I said, it is a bridge for other therapies. So one of the things I just want to point out is that you should know your policy in your institution if you need an order to place pads on a patient. Also, know your equipment. Some pads are all-in-ones. Others require a 3-lead system that require to do the demand pacing. So most pads with a defibrillator that has pacing abilities, you can pace and defibrillate through those pads. But again, some monitors do require you to also put the 3 leads on so that it can sense the patient's own intrinsic beat and inhibit the pacer when needed. Usually you would put those pacer pads on anteriorly and posteriorly. That is the preferred method. And looking at the pictures of your pads, again, know your pads that you have in your facility and make sure that you know how placement should be done. So when using the device, many like it because as soon as you turn on the pacing, you all of a sudden see spikes appear. And therefore that's showing that the pacer function is on. So after turning on the pacing, you can set a rate, if you can, and usually look at your monitor to determine where everything is, and you should always take some time and play with your monitor to get familiar with it, because in an emergency is not the time for you to kind of play. So when you turn it on, it usually will default to a rate, oftentimes 70, because 70 beats per minute is usually conducive to life. So once you have, and again, that's usually higher than the patient's rate, because normally your heart rates are going to be above, below 70 if you need a pacemaker. So once you set, the rate is set, and again, it is usually defaults to about 70, then you will need to set the output. This is milliamps, and you want to turn up your milliamps quickly, and this will turn up so that until you get a captured beat. So every pacer spike is followed by a QRS. It usually will take up to 50 milliamps or more to produce a captured transcutaneous pacer. And again, remember, the pacer means that you have a pacing stimulus, which is that little spike, and then you'll see a wide QRS that is depolarizing the chamber being paced. So look at this. What does electrical capture look like? So the pacer spike is actually an artifact showing the impulse that has been generated. So this is an example of 100% ventricular paced rhythm. The pacer spike is the pacer firing and is seen as a ventricle straight line, or excuse me, vertical straight line on the EKG paper. When the ventricle is paced, the complex appears like a originated from the ventricles would, because you're only pacing the ventricles, and therefore it's going to, and one side of your ventricle, so it's going to be wide, so it doesn't go down the bundles of His that would cause you to have a narrow QRS. So you would see it almost looking like PVCs or idioventricular, but it's, you know, it's not premature, but it has a pacer spike right before. And we're going to look at strips of paced rhythms later in this presentation. Once electrical capture is reached, check for mechanical capture, and we would do that by checking a pulse. Always confirm, not only on the monitor, but also confirm that you have the patient's pulse matches the same rate that you're supposed to be pacing at. I've heard some people say that if you don't have mechanical capture, keep increasing the milliamps, which is not always true. If you have 100% electrical capture and no mechanical capture, you have actually a patient in PEA, and you need to treat the patient for that. Let's go into transvenous pacers. So there are atrioventricular or AV transvenous pacing catheters, but I don't think anyone uses them around here. We're going to mostly focus on transvenous pacers that primarily pace the ventricles. know the process for your facility and who would be doing them. So who inserts the pacemaker? Usually it's an interventional cardiologist or a critical care doctor, or they go to the cath lab. So know who puts those in. So they usually will have a pacing catheter, which is inserted by the physician, very much like the central line through a vein, either jugular, subclavian, or femoral. Then those leads are attached to an external generator, and it's used for short term, not for months, just days or up to a week, kind of like what you would have for like the amount of time you would have for a central line, because of course there's always a risk for infection. So when we look at the generator, we sometimes may call that pulse generator or a pacer box. Most institutions have very specific routines for how generators should be secured for safety so that it doesn't accidentally get pulled out. Securing the patient's arm on an IV pole next to the beds are examples of methods. Pulse generators, again, they contain the power source, usually a 9-volt battery. And when you have that settings, you always want to make sure that the settings are included, that they're correct to when the doctor or the provider has determined what settings they should be on. You have settings such as your rate, the output, or the milliamps, that's the energy, and then you would have sensitivity. And again, we're going to talk a little bit more about sensitivity in a little bit. The epicardial pacemakers, these are temporary wires that are placed on the outside of the heart. So that's your epicardium. Usually it's done during cardiac surgery and through the skin and attached to the chest, as you can see by the pictures. You will see frequently both their atrial and ventricles are being paced. It again will be attached to a generator that's externally, and your atrial pacing frequently is treated to avoid atrial fib, so you can make sure that your patient has that adequate atrial kick. And this as well would be removed after a few days. There's also, an additional ground wire that is secured to the skin and the chest wall in some cases. Now let's talk about permanent pacers. Permanent pacers. This is where the patient's heart is unable to maintain normal heart rate and therefore adequate cardiac output. The generator is surgically implanted. It's as small as you can see, about fits in the palm of the hand, and it will be placed in a tiny little pocket within the patient's chest. The lead wire is inserted into the heart through the large vein, as you can see from the picture. Let's talk about the different types of permanent pacers. Just so you know, this information is not on the test, but it will help you have a better understanding about the different types of pacers, especially with different chambers. So atrial pacer, the lead wire is in the right atrium. That electrical impulse is generated by the pacer stimulates the atria, then follows the normal conduction pathway to the ventricles. The ventricular pacer single chamber lead is in the right ventricle. Also, AV sequential, atrioventricular sequential, the lead is in the right atrium and the right ventricle. Then you have a biventricular. Biventricular pacers, lead is in the atria and each ventricle. These are used to synchronize the contraction of the ventricles, which in a heart failure may be asynchronous due to enlargement of the ventricles. So it can be used for patients who have a severe cardiomyopathy or left ventricular hypertrophy. Oftentimes you may even see pacer defibrillator combos, where not only do they have a pacer, but they also have an AICD, which is an automatic internal defibrillator. So with clinical management, there's a couple things you should be aware of. It is very important to make sure you have patient and family teaching. Let them be aware of how to take care of themselves, things to avoid. Always check the effect of pacer malfunction on the patient's hemodynamic status. A 12-lead EKG should be done to assess the pacemaker malfunction. And be aware that you should wear gloves when handling wires from a temporary or epicardial pacer to reduce incidence of static electricity interfering with pacer function. But there are some new insertion guidelines which include activity restrictions such as a sling. Oftentimes you want to restrict arm movement, and that's part of that patient-family teaching. We had a permanent pacer lead dislodge recently. Watch for signs and symptoms of infection or bleeding at the insertion site. So these are all things that you want to monitor for your patient. And reps will usually bring in interrogation devices for specific brands so they can monitor and make adjustments to these settings. Let's talk now about pacer terminology and paced rhythms. So what do we need to know with pace rhythm? Pacers are a very big topic, and we could spend several days talking about them. We are giving you an introduction, the very basic and focusing on the very basic rhythms and malfunctions that can be dangerous. So we're just brushing the top of this information and try to give you what's important. So we're going to talk primarily about what's a normal paced rhythms, normal identified pacemaker malfunctions, which would include failure to sense, failure to capture, and failure to fire. The number one rule for paced rhythm is that in order to determine if a pacer is functioning properly, you have to know what kind of pacer it is and how it is programmed. That being said, it is often a bit of a challenge to find out with permanent pacemakers. Pacer reps will come in with special device to interrogate the pacer and check its function. For testing purposes, we will only be focusing on single chamber ventricular paced rhythms. In talking with pacer terminology, we're talking about the pacer spike. So the discharge of that electrical energy is actually artifact, and it looks like a vertical straight line. And you may see different sizes of that pacer spike, and that usually is due to whether it's unipolar or bipolar, because unipolar leads produce a bigger spike than a bipolar lead. Again, this is just something that is, why does it look different from one patient to another patient, is usually why we tell you that. If the lead is in the atria, the spike will be followed by a P wave, so it's causing a depolarization of the atriums. And if the lead is in the ventricle, you will see a spike that will be followed by a wide QRS, because it is only pacing on the one ventricle, and that impulse has to send the depolarization message all the way to the other ventricle, which takes time, and that creates that wide QRS. So capture is a QRS following a ventricular spike. It is wide because the complex originates from the lead in the ventricle, and again, just like the patient's own beat, if it started in the ventricle, it's going to take time to go from cell to cell to cell to cell to cause both ventricles to depolarize. And its P wave is followed by pacer spike in the atria, and QRS is followed by a pacer spike in the ventricle pace. And as you can see in here, the QRSs are following a ventricular spike. It is wide, again, because it's originated from the lead in the ventricle. Most generally, it's going to be in the right ventricle that the pacemaker lead is inserted. Capture is determined by the strength in the stimulus measured in milliamps. So, in order for you to get a captured beat, you need to have energy. We measure that in milliamps. What the pacer wire does is it contacts in the patient's myocardium, whether it's embedded and impermanent or sitting on the myocardium inside of the heart, and it's triggering that impulse with a measured or a preset of measured milliamps. Capture can't occur unless there is a healthy myocardium capable of responding to that stimulus. So things like if the patient had an MI, that infarcted tissue cannot be conducted. It doesn't conduct. Sometimes placement of external pads does not always work, especially in some patients that are very large, and sometimes placement with an internal wire. So these are things that may show that the patient's pacer is on, but it's not actually capturing. There was a case scenario there once in a code. The ICU nurse thought they were doing something wrong with the transcutaneous pacer as they could not get it to capture. And checking everything, they had it all right. The milliamps were increased to the max, which is at 140 on an external pacer. It did not get capture. And what basically was happening, this person was on multiple pressors and had been there for days, and end of life, the family and the physician were not accepting. The code had already been going on for some time, about 30 minutes, with no viable myocardium to pace. Dead tissue basically is dead tissue. And the patient's own rhythm was a bradycardia PEA, which finally convinced the physician that the milliamps was as high as it can go and were unable to get captured. And again, it took getting an ultrasound machine to prove to him that there was absolutely no myocardium in motion. So a pacemaker is not going to be the treatment for someone in PEA or asystole, because if there's no myocardium, it's not going to be receptive to impulse. So you don't really need to memorize how much milliamps, but just know with the pacer terminology, pacing with a transcutaneous pacer requires a lot more milliamps or output than pacing with a transvenous or epicardial, because you have to go through thickness of tissue to get to the heart, and as opposed to when you have the temporary wires, one's either inside the heart or on the outside of the heart that has direct contact with the tissue. Where the transcutaneous milliamps usually would run between 50 to 140, as opposed to the transvenous epicardial, and epicardial would be 0.1 to 20 milliamps. For the pacer settings, the generator can be set to initiate a rate of electrical impulses by one of two methods: either fixed, which generates electrical impulses at a constant rate, regardless what the patient's underlying own heart rate is, or a demand mode, which is set to sense the patient's underlying heart rate and supplement it to maintain minimum number of beats. So looking at comparably side to side, so with a fixed rate, let's say is set at 70, we'll deliver 70 pacer spikes a minute, no matter what the patient's heart rate is doing. If the patient's own rate or intrinsic rate is less than that, we'll say their own rate would be 60 without the pacemaker, then what you're going to see is a constant 70 beats per minute of 100% paced rhythm. If the patient's rate is more than that, then the pacer is not capable of sensing the patient's own rate. So if the pacer is set at 70, but the patient's own rate is 80, 83, then what will happen is that the pacer will just keep firing at a set rate of 70. And therefore, it opens that up to a potential issue, because it can deliver a spike and possible captured beat at very vulnerable times in the cardiac cycle, kind of like a premature beat could. But in demand mode, that's a setting where the pacer will sense the patient's own rate, and it will only fire or pace when it needs to. And again, kind of like an escape rhythm does. So when your SA node fails, your junctional may kick in, or if your SA and your junction fails, then your ventricular escape beat would come in. But this pacemaker will kick in when the set pacer rate to make sure that patient does not go below that set rate, and senses the patient's own so that it will only come on when the patient needs it. Continuing pacer terminology, sensing. So with sensing, the pacer is able to detect the presence of the patient's own intrinsic cardiac activity, the patient's own rhythm. And we can adjust that sensitivity only on types of pulse generators shown in transvenous or epicardial or permanent. Permanent pacers actually need interrogation equipment to do it. However, transcutaneous pacers in demand mode will sense intrinsic activity if properly set up. And there isn't an adjustment level on the transcutaneous, so you have to be careful because the patient may have artifact. So make sure that you have a proper setup, and means that, you know, depending on the type of pads you're using, you may also have to attach the leads, the 3 leads system, to see the patient's own rhythm and allow the pacemaker, the external pacemaker, to sense the patient's rhythm. So with sensing, the pacer is able to detect the presence of intrinsic cardiac activity. To increase sensitivity, you actually decrease the number. For example, a setting of 2 millivolts is more sensitive than 5 millivolts. And we'll use kind of like a fence analogy for sensitivity. And so sensitivity is a fence standing between the pacemaker and what it needs to see. If there is a 10-foot high fence or a 10 millivolt sensitivity, the pacer may not see what the ventricle is doing. The fence needs to be lowered. So changing the sensitivity from 10 millivolts to 2 millivolts is like lowering the fence from 10 foot to 2 foot. However, the pacemaker may then see more than it needs to, such as artifact, and it doesn't pace when it should. So the size of the fence needs to be just right. And we measure in the millivolts is in the size of the activity. We want it to be able to detect the patient's QRSs, but we don't want it to detect like a P wave is an QRS, or else that sensitivity would need to be turned up. So, what way to turn the dial is not on the test. Again, if you do use temporary pacemakers, and your role would be determined on what unit you work in and what your institution allows you to do. We're going to talk about the ventricular paced rhythm. And just so you know, only ventricular pacing strips will be on the test, not biventricular, not AV pacing, just the ventricular paced. So with the ventricular paced, a normal, and what you can see from this strip is an example of 100% ventricular pace. The patient has none of their own intrinsic rate going. So the rhythm is usually regular from spike to spike. And the heart rate you would count between the spikes just like you would R to R. So you can see what the pacer spike is set at. So there would not be P waves, so therefore you would not do a PR interval. The QRS is going to be wide because it's originating in the ventricles. One side of the ventricle, usually in a pacer, is going to be the right ventricle, and it has to trigger that impulse, and that impulse has to travel through Purkinje fibers and cell to cell in order for it to depolarize both ventricles at, within the same time, but it's not as fast as if it was going down the bundles of His. So in this rhythm, your interpretation is 100% ventricular paced. For demand pacing, remember, ventricular paced complexes will only be on the test. We're not looking to do AV pacing or dual chamber pacing. So with this rhythm, you have a ventricular paced complexes with an intrinsic complex, which is normal because the patient, if their heart rate goes up, we want the pacer to be inhibited or not to fire. So what you're going to see is, for characteristics, you're going to see both intrinsic, patient's own beat, and paced beats, which can be seen. So if the intrinsic rate is faster, so if the patient's own heart rate is faster than the set rate on the pacemaker, then you can see the intrinsic beats. You won't see paced beats because, again, it's being suppressed because the pacer does not need to fire. So rhythms that will appear 100% paced is only if the intrinsic rate, or the patient's rate, is slower than what's set. So if you can see in this, that circled fifth complex is the patient's own rhythm. When we talk about fusion beats, these are normal. So what that means is that, again, the pacemaker is on demand. They are not as common as the number of examples you'll see in the book, would lead you to believe. We would basically will see a pacemaker fires at the same time the patient's own intrinsic beat occurs. It's almost like the pacer is ready to fire and the patient's own beat came in at the exact same time. This is normal. The thing that you're going to see differently within the rhythm strip, as you can see on on A, B, and C, on the C complex, is it is kind of a combination or a blend of a pacer spike and the patient's own intrinsic beat. So with that said, a fusion beat is basically a blend of both a pacer and a intrinsic, and it is normal. It's just the patient's firing at they're trying to create their own heartbeat, but the pacer did not sense and it says, oh, I'm ready to go, but it just happened to happen at the same time. So now let's talk about pacemaker malfunctions. The first one we're going to talk about is failure to pace. It's also known as failure to fire, and this is life-threatening. That means the pacemaker is not firing at all, and it fails to deliver any pacing stimulus. And when there's no pacer that's functioning where there should be, then what's going to happen is the patient will become bradycardic because their pacer is not firing, and they can become hypotensive, or if they could potentially become asystole. The causes, or the possible causes, of failure to pace is usually pacemaker is off, so make sure you check your settings. The battery failure, so always make sure you have a fresh battery in there and change it every 24 hours, or if it's a permanent pacer, they would be interrogated and they would be able to see the battery life. It could be due to faulty cable connection. If it's an temporary pacemaker, make sure that the cables are connected and they are kind of tightened in there. Or it can be due to a dislodged or a fractured lead. Oversensing. So this means that it may be a cause of failure to pace because this is proving to be the pacemaker is picking up very small movement as if that's the patient's own beat. So like picking up a P wave thinking it's a QRS. So therefore that's when you need to turn the gain up, or the sensitivity up, so that it will make only bigger things to be able to be sensed. If you do have a patient with a permanent pacemaker and they are failing to pace, then you would need to apply a transcutaneous pacer until the problem could be fixed. So you may see failure to capture. So failing to capture is basically the pacer is firing, just like when you first turn on an external pacemaker, you're going to see those spikes going wrong. But what happens is it's telling the heart to depolarize, but it did not respond. So what you're going to see is a pacing spike that occurs on time, but it is not followed by a QRS. The problem with failure to capture is that it can cause bradycardia and hypotension. Even though the pacer spikes are there, there's no captured, which means there's no electricity creating a depolarization, and therefore there's no pulse, mechanical or a pulse that's causing a cardiac output. So the patient will present with bradycardia, hypotension, and fatigue. Failure to capture and the life-threatening. So this is an example of failure of the heart to depolarize following a pacer stimulus. And this is basically a complete loss of capture because the patient's in asystole, and that's why it's life-threatening. And pacers do not, you have to have viable myocardium for it to depolarize. So in asystole, it does not work to put a pacer on. You cannot put a pacer on asystole. It does not do anything. So with failure to capture, it can be life-threatening. And let's look at your possible cause and what you would do about it and your action. So because that pacer spike is just saying that there is a delivery, but you have to give energy or milliamps output. So therefore it is too low. So you would need to turn up the milliamps until you again have 100% captured beat, or you've achieved that. Other things that can cause, if the pads are displaced. So if you have a external or transcutaneous, you want to make sure you check the contact, make sure that the pads are not dried up, you have a good conductant, and again, if you have to, replace the pads and make sure that the connections are all intact. So checking your connections. Other things is like the lead is displaced or fractured. So sometimes if you have a displacement, if you turn the patient on their side or turning, it may cause the lead to come back in contact with the myocardium. You can try either side, but if it doesn't work, then you would need to use a transcutaneous pacer. And again, the physician may need to, if it's a temporary wire, may need to reposition that lead. Another is infarcted tissue. So the lead may need to be repositioned. If it's a permanent pacer, it may need to go in and have a new wire, a new lead put in. Other things is electrolytes can also cause a pacer to fail to capture because electrolytes are very important with the depolarization of your cardiac cycle. In failure to sense, this also life-threatening, it occurs when the pacer does not sense the patient's own or intrinsic beat. So what you can see on the strip down below reflects is the pacing spike is occurring where it shouldn't. So it's too close behind the patient's own intrinsic beat. The problem with that, it can cause a couple things. It can cause the heart rate to go up for palpitations. You can cause skipped beats. And if it lands in that R on T and does produce a captured beat, it can occur VFib or VTAC if it occurs during that refractory period. But this spike in this picture falls on time, but the pacer did not sense the ectopy. So if you did your pacer rate from pacer spike to pacer spike, it came in as if it did not see that patient's own beat, which actually in this case is a PVC. But it could be any beat. It would have been the patient's own beat rhythm that could have happened. So it is important to note that that pacer spike is too close and did not sense the patient's own intrinsic beat. So also possible causes and actions. So the pacer mode is set at a fixed mode, which means that it's asynchronous. Asynchronous mode, we have to set usually the pacer to pace no matter the patient's own rhythm. So of course it's not going to sense. So for the test, assume all strips and pacers are in demand mode. Okay. So, but asynchronous modes mean that it's a fixed mode. It's going to fire no matter what at the rate that is set. Other things that can be failure to sense is the sensitivity is set too low. So you need to adjust the sensitivity in the transvenous pacer. If the lead is displaced or fractured, then again, try turning patient on the side, And if needed, you will have to apply a transcutaneous pacer, or the physician may need to reposition that lead. And if it's infarcted tissue, the lead may need to be repositioned as well, because again, pacers do not work on infarcted tissue. Infarcted tissue does not depolarize. So with your paced rhythm analysis, so we're going to look and identify the pace beats, and you also want to see if there's patient's own beats are in a rhythm. You're going to measure the pacer spike to pacer spike. So spike to spike is kind of like what you would measure P to P or R to R. The book calls this automatic interval. We want to know if the pacer spike falls when it's expected. Is every pacer spike followed by a QRS? And is the pacer spikes when expected? So are the pacer spikes where they don't belong? So are they too close to the patient's own beat? So you would need to know what the underlying automatic interval is, or pacer spike to pacer spike. So what would you see on an EKG strip if the patient had failure to capture? You would see a pacer spike not followed by a QRS or a P. Okay. Here's the next quiz question. What would you see on an ECG strip if the patient had failure to sense? So the answer would be you would see pacer spikes where they shouldn't be. Basically what you would see is the patient's own intrinsic beat, and then a pacer spike too close to the patient's own beat, so therefore showing that it did not sense it or see it in a sense. Let's do some practice strips. We're going to do 1021, 1023, and 1028. What I would advise you to do is pause this video, do the practice strips, and then we'll return the video back on and we'll go over those, each of them. Okay, let's do strip 10.21. In this strip, what you're seeing is that you have 100% ventricular pacing and capture. This is normal pacer function. Just to put it in perspective, if you were to take your calipers or a piece of paper and try to measure the heart rate, you would go pacer spike to pacer spike, and that actually comes up to about 70, 71. So this pacemaker is set at a rate to fire at 71 beats per minute. Strip 10.23. So in this one, what you're seeing is that you have 4 complexes. The first 4 complexes are ventricular paced and captured. Then what you see is a patient's own beat comes in, and then what you're also looking at, see that pacer spike right in the T wave. So what that means is that pacer spike is too close to the patient's own, and it failed to sense the patient's own beat. With that said, that's the danger, that if that pacer spike did capture, that could have caused the patient to go into cardiac arrest, go into VFib. So it did not capture, but it's too close to the absolute refractory period, so that's why it did not. So that's failing to sense. So again, trying to figure out how and put it in perspective. So the pacer is actually, if you do pacer spike to pacer spike, I believe it's set at about 63. So again, you're going to count how many boxes between pacer spike to pacer spike. Now, the patient's own intrinsic beat in the 5th complex came in at a rate, if you go from the pacer spike of the 4th complex to the R wave of the 5th complex, that would give you a rate about 88. So the patient's own rate came in above the set rate. However, the pacer did not sense that patient's intrinsic beat and fired at a set rate of 63, and that's why it landed right in around the T wave of the patient's intrinsic beat. Now that's the fifth complex. The sixth complex is a fusion beat, which basically is a combination between, or a blend between, the patient's intrinsic beat and a paced beat. And then the last beat is a captured ventricular paced. In strip 1028, so first four complexes are ventricular paced and captured. Then what happens is you have two pacer spikes with no QRS, so you have failure to capture. So there's spikes not followed by QRS. Then you have the patient's own intrinsic beat, and then you have more spikes, but not followed by QRS. So what has happened is this pacer is basically failing to capture after the four paced beat. And the book does not address the bumps following the spike, not followed by the QRS, but looking down at the strip to the thing between the spikes, that looks like a P wave. And we're wondering if they are the patient's own P wave that coincidentally came after the spike. Again, if he measures out the P to P, it's probably like a complete heart block or something. In summary, this concludes the pacer lecture. Just to review, failing to capture means that the pacer is firing at the set rate, but there is a pacer spike with no QRS complex following it. Oftentimes you're going to see more of a bradycardia. In failing to sense, the patient has their own intrinsic beats occurring, but the pacer does not see them. So you'll see pacer spikes or captured beats too close to the patient's own beat, where it should be the same distance from the pacer spikes previously. Thank you, and I hope you do all your homework so that this will reinforce this knowledge.